afternoon. Thank you, Dr. Maher, for giving me this opportunity. Thank you, Bobby Jones Foundation. I have to be honest, this is my first time hearing about your foundation, and this is my first time being to this building as well, even though I have been at Stanford since 2008. My name is Xiang Qian. A lot of people call me XQ because they just cannot pronounce my last name, so I actually pronounce it as Qian. So I am trained in pain management, and over the last 10 years or so, I became so interested in facial pain and headache, and such that I found a niche here at Stanford. A lot of my neurology colleagues, they treat headache, but they mainly focused on medication management and psychosocial management, etc. A lot of pain management doctors are not so much into headache management because a lot of times it could be a headache for them. But I have found passions in this, special subspecialties, and I would like to share my experience with you by starting with two cases that I run into. One case is from my colleagues from Mayo Clinic, and the other case is from myself, and both of them are related to Chiari. For identity purpose, this patient's in 20s. She's a female, and she had this headache onset for about 1 year. As you can see, that she has infrequent migraines since the teenagers, but never really, became so serious about it. In 2021, she got this COVID infection, and then afterwards, she developed this worst sinus headache that has really bothered her. But she didn't really think this is, something specific. She tried everything and get this and that, and she, you can see that she had this 2 to 7 minutes of pounding occipital headache that worsened by coughing, right? But, it's normal to have a cough after infection. Didn't really think about that until about a year or so later, and the symptoms not going away, and it's really bothering her, and she came to the clinic, and they, started to do the workup for her. And then as it's such, her headache is very different. It's not a particularly positional. Lying down doesn't get the headache better. This is not a migrainous, even though she had a migraines histories before. Other histories, relatively speaking, is it's back and neck pain, some hypertension, maybe mild chronic kidney disease, but no headache history in the family, no allergies, etc. Didn't really taking that much medicine other than she started to her local PCPs gave her some amitriptyline. She couldn't tolerate Diamox and couldn't try indomethacin NSAID because of her underlying kidney disease. Exam, it was not nothing specific, full neck range of motion. The labs, they did show the MRI, which Dr. Comack just showed all, and you can see that her MRI, she has tonsil below the magnus, and it's about 13 millimeters. So the questions for the audience, and I have to be honest too, I didn't know the audience was a patient or versus physician, so I assume it was patient at the time. So is this cough headache related to Chiari or something else? And what other management would you suggest at the time? So before I give the answer, I'm gonna move on to the second case. This is a relatively a lot more complex case. This is my patients for the last 2 years or so. She was in 50s and female, similar BMI, and her headache since she started to have it was almost 30 years. This is a long history of illness, as you can see. Almost, 20, 30 years ago, she started to develop left side facial pain at the time. And the pain was in the ear, traveled down to the jaw, into the tongue. And they initially diagnosed this as glossopharyngeal neuralgia because some of her imaging showed some steroid, calcification at the time. And they started to give her all the glossopharyngeal type of medication. Didn't really help, but she kind of toughed through. She got married, raised a family, and then a couple years later showed Chiari malformation type 1. And she was referred to neurosurgery. They did surgery at the time. Unfortunately, the surgery didn't help that much, but the pain persisted. As you can see, a year later, she implanted a motor cortex stimulator, which is quite invasive, right? It helped to some degree, but unfortunately, it was infected and has to be removed. And then over the next couple of years, she's just getting infected, but her pain is so bad, she just won the device back. She got reimplanted. It somewhat helped, but then got reinfected. So it was really unfortunate for her. And in 2005, she started to have this horrible pain on the right side, on the other side. And at that time, the motor cortex stimulators has been removed due to infection again. And over the next couple of years, is really struggling. I didn't know this patient even back then. I was a resident in 2009. And we started to implant her in occipital stimulators by our neurosurgical colleagues. Somewhat really, it's not really per her cause, not really helped. But the devices was, there because she was desperate. She didn't know what to do. As you can see, over the years, she had multiple reconstruction surgery, plastic surgery to kind of reimplant, move around. It didn't really help her. 2022, just 2 years ago, she even went for decompression surgery in the occipital area to cut out those nerves, because her headache is really just back of the head, kind of radiating to the head every day, debilitating. So last year she presented to me. I don't know how, and for some reason she was just routed to me in the end. I think it's the end of rope, like in terms of what to do. She was telling me her pain was in the right eye, and starts from the back of the neck, radiates on top of head, and then go into the eye, kind of sharp and stabbing. Okay, she has to lie down on the other side and not to move to kind of calm down a little bit. And of course, the light make her pain worse, and she also has some sort of a nausea as well. This is happening on a daily basis, you have to imagine. And this is highly functional a person. In spite of this pain, she continues to kind of work through and tough through every day and raising the family. Cough does not worsen the pain. So that's kind of her situation, her story. It's not migrainous, right? The cough doesn't worsen the pain. So the questions for the for the audience, let's look at the history again. I mean, of course, over the time she developed depression. There's some sort of seizure disorder as well, but she was on Keppra, really didn't have a major seizure since then. She has some cervical arthritis, allergies over the years. She was putting on the opioids, etc. Fortunately, she developed allergies to it. She's not on it. Common medications, Keppra, gabapentin, Prozac, and then methadone. Unfortunately, this is one of the medications she was on. And that's kind of her story. And an exam, as you can see, that she can have pain when looking up and down, but her range of motion is still okay. There's tingling on the left side, but no numbness. And the right side is really, occipital area is very tender on palpation. And then I ordered a brain MRI. Didn't really show any new changes. It's all just the post-surgical changes. I think, in spite of having surgery many years ago, the C1 laminectomy for the surgery kind of already fixed the problem. So the question to the audience is is her headache related to Chiari? Or there's something else is going on there? And then what kind of a management would you suggest for her? So, and then Dr. Mara, you already touched some of this, but the Chiari and the headache, and it's really, it's not. The diagnosis is made not clinical, but by MRI, right? But it may not be true because this is kind of a simplified versions here. This 5 millimeter, we just went through that. But I wanted to comment is that it occurs really high numbers of patients here, right? The symptoms could be like we said, that we wish every patient would present with this classic presentation, that we wouldn't be having these conversations here. But if you look at this headache as a first presentation, only about 50% of them are cough, headache, and the other 50% of them is not, right? And there's about 30% of them, one third of them are migrainous-like, and with or without migraine as history. The problem is, 10 to 15% of our population have migraine, and now you have this on top of that. You just don't know the causation relationship, which one happens first, which one happens, second. And then the other 20% is tension-like headache, okay? So, and then there are also other patients that could not having a classic symptoms like headache, right? It could be others, vertigo, dizziness, and gait, etc. What I wanted to touch on as a pain management doctor is the mechanisms. That there are a lot of studies pointing down to the headache mechanisms for Chiari is this transient intracranial pressure elevations will sensitize, will activate the trigeminal systems, okay, the trigeminal vascular system. So what exactly, okay, so I have other slides. I'm going to talk about trigeminal nerve. Before that, I want to kind of go overall recommendation from a pain management doctor's eye is that for the typical cough headache, there's no questions. I'm going to refer to our neurosurgical colleagues, okay? But for migraines or tension-like headaches, I think you really have to be cautious. And you want to look into the psychosocial biological component of this headache. You want to make sure that you're not missing other contribution factors to the headache before you make a referral to the surgeon colleagues. You also want to let the patient know that, don't rush for a decision. Don't rush for a surgery, because the worst it is that you undergo a surgery and then your headache does not change, or the headache gets worse, right? That's kind of really hard to do. And this is kind of a summary slides about like if you presented with a cough headache that we just touched it, briefly by Dr. Mahar. I would say that we have a little bit of debate in Hong Kong as well in terms of how long this should last. And pain is such a difficult, kind of a feelings for you to tell the doctors, right? It's both objective and subjective. There's a lot of things going on there, and how long this could last. 5 minutes versus a second versus 2 hours. And I think in conclusion, it's a very brief headache. It's not a long headache. Like a migraine headache will last more than 4 hours or days sometimes, right? And then, of course, the reason is that the pressure changes, sensitize the nervous system, and you get this headache issues. And I don't want to go into the treatment there yet, but obviously I think that, the medication really doesn't work that well for cough headache, and it's not a definitive treatment neither, right? Just treating the symptoms. Versus the migraine, like say, if you compare with migraine, the diagnosis criteria is that it really lasts much longer, and it has to be associated with a lot of those autonomic symptoms, for example, nausea, sensitivity to lights and sounds, etc., right? And the pathophysiology is quite different as well. And then, of course, the treatment is very different too. And then the next slide is for tension headache. Tension headache, again, the clinical presentation is different than migraine, and the pathophysiology is different. But the treatment is somewhat similar to the migraine, which is that we're using the so-called 4-pillar treatment, okay? Using pharmacological, procedural, psychological, and then physical and occupational therapy. So I'm not going to dive into those details in terms of how we treat those conditions pharmacologically, but those are some of the common steps that we're going to intervene through the pathway. But there are 2 treatments I wanted to kind of introduce to the audience that we're providing for cases that failed other treatment, or they wanted to try before surgery, and I think we have seen some success. One is inpatient lidocaine infusions. As you can see from the slides, it's a sodium channel blocker. It inhibits the neuronal activities, but more importantly, in our view, it helps kind of reset the pain pathways in your brain. If you have a sensitization process going on there, this might help reverse the process. Let's say if you have headache for more than 5 years, if you have headache for 10 years, even if it's cough headache, before you do decide to do, a surgery, would you want it to kind of help precondition yourself, optimize conditions for surgery? I mean, I think it's something you can consider. Or you're scared of surgery, or if you feel like your body is not fit for the surgery, there's some other option that we can try for you. And of course, there's inpatient ketamine infusions. In ketamine infusion, You may have heard about this all the time with recent news, with Matthew Perry's and passing away with the ketamine. There's a Meyer case in Florida, etc. But the bottom line is it is a very, very safe medication. It has to be used under, strict guidance, monitoring. If you're using it in the right way, it's a very safe medication. And it could be very effective for headache management. And we admit patients to the hospital for 5 days ketamine infusions at the dose, sub-anesthetic dose. Most of the patients tolerate very well, and it could be quite helpful for headache patients to break the cycle, and then it could also be very helpful to help renormalize this, this sensitization pathway, which I'm going to show you in the next few slides. So that's the pharmacological approach, right? So for the procedural approach, we have lots of them, like nerve blocks, nerve stimulations, and etc. But I wanted to focusing on the neuromodulation part to the audience today. So before I go into the details in terms of what kind of neuromodulation we can do, we can help, we wanted to review the anatomy a little bit of the head, okay? So basically there are 6 main ganglions in the head and the neck. Ganglion means a cluster of neurons, right? There are 2 sensory ganglions, which is the trigeminal ganglions and the upcervical nerve roots, C1, C2, C3 dorsal root ganglion, okay? And then we have 2 parasympathetic ganglions, which is the sphenopalatine ganglion, like kind of in the sinus area. We also have this aortic ganglions. It's kind of interesting. So those 2 ganglions are providing parasympathetic tone to the face. For example, like tearing, nasal discharge, kind of salivary glands, and etc. And they also are responsible for the vasodilation of the face. And then there are 2 sympathetic ganglions in the neck. One is called superior cervical ganglion, and then also stellate ganglion. Stellate ganglion, by the way, there's a lot of new research going on about its potential role in headache and long COVID syndrome. So those 6 ganglions, they all kind of merge together into the brain to form this important pathway. And the major player there is the trigeminal nerve ganglions. Remember that we talked about before, one of the mechanisms behind beneath the Chiari headache is the sensitization of trigeminal efferent pathways, the nerve terminals on the head, and that will relate to the vasculatures to cause vasodilation, and then you feel headache. So if you look at this face, we have 3 branches, 1, 2, 3, on the face, okay? In the forehead area, eye, cornea, in the face, in the jaw, in the tongue, the teeth, roof of the mouth, they merge together to go into this descending ganglions and in the middle brain fossa. And then they would project into the trigeminal nerve nucleus of the brainstem. And there is going to be another input from the cervical side, which I'm going to show you as the next, I think I'm going to, before that, okay. So in this pathway, I wanted to comment one of the molecules is really, really important. If you happen to have a migraine, I'm sure you heard about CGRP antagonists, right? So the Aimovig, for the last couple of years, is one of the major players. So the trigeminal nerve systems, upon activation, it will release this CGRP, calcium gene-related peptide, as a neurotransmitter, as a main neurotransmitters. And that will pick up by the receptors on the meningeal blood vessels. That will cause massive vasodilation. That is one of the key mechanisms we think is behind this migraine or headache or tension headache or Chiari headache, that process. And as you can see, this trigeminal ganglions and the nucleus caudalis plays a huge role in terms of controlling the activities, in terms of how much you would release the CGRP. So one of the treatment is to find that something can antagonize the CGRP, right? So in 2022, the Brain Prize was for the first time given to this 4 scientists for their 4 decades of work that they developed the CGRP as being one of the key target for headache and migraine treatment. And Pfizer, by the way, they acquired Biohaven's for a huge amount of money 2 years ago because they see the potential for headache treatment. So right now, like migraine headache patient, you could get access to many of those mono antibodies, the drugs available, as well as the small molecules from Biohaven. Now, let's go back to the slides again. So the trigeminal ganglion, and then it goes into nucleus caudalis, and then you also, this headquarters here also receives input from the C1, C2, C3 spinal nerves. Among them, one of the major players is the cervical 2 dorsal root ganglion. And those 3 head ganglions and their interactions converge to cause headache and facial pain. So this is basically laying down the foundations for the neuromodulation devices for the head, okay, for headache. So there are many neuromodulation devices now is amenable to treat headache and facial pain. For example, refractory chronic migraine, intractable headache, including Chiari malformation headache, cervicogenic headache, cluster headache, etc., as you can see. And there are 2 different classes. Okay, first class is, of course, is the non-invasive, the wearable devices. As you can see, basically they're targeting different nerves. So for example, the cephaly, by putting on the forehead, they're stimulating the supraorbital, which is the V1 branch of trigeminal nerve, right? And you got this TMS, the occipital cortex transcranial magnetic stimulation. That's kind of directly acting on the TCC, trigeminal cervical complex in the brainstem. And then you also have this combined occipital and trigeminal nerve stimulators, Relevant. So it's kind of like a ring of stimulators can activate 6 nerves together. They all are FDA approved, and right now it's all clinically available to treat varieties of headache patients, including our own populations of patients. Now, I am more of a kind of into this implantable device sectors. So right now, the work is mainly focused on the greater occipital nerve, which arise from the C2 DRG we just mentioned a few slides before, as the treatment target for headache. The levels of evidence is actually pretty good. As you can see, there's level 1 for occipital nerve stimulations. There are 5 randomized control studies for that. 4 of them for chronic migraine, 1 for cluster headache. Of course, there are some other evidence for SPG as well. Okay. I will not go into the details. Unfortunately, the occipital nerve stimulations is still not FDA approved. The main reason is that there are 2 reasons. Number 1 is we don't have a dedicated device for this type of nerve target. We're using the spinal cord stimulators as off-label use to treat, to target this occipital nerve. They're very bulky, they're big, and therefore the complication rate is really, really high. For example, like infection rate is more than 20%, so that's not going to fly with FDA. And then the other reason I believe is what my next slide is going to show is I don't think they're targeting the target they should target. The occipital nerve is too peripheral. What we can do is to move to a more ideal and better improved target, which is the C2 DRG, which I'll show you in a few slides. So those are the FDA approved for PNS options, by the way, because the spinal cord stimulator, we see some problems because being bulky and expensive, and so therefore, over the last 10 years, the FDA have approved a couple more minimal invasive devices options. For example, the bionic stimulator and the Sprint. Sprint is temporarily 60 days, but those devices are approved for other non-cervical, non-headache nerve targets, like sciatic nerve, let's say back nerves. So we still don't have a product approved for headache yet, not yet. This is just how they look like. And this is how we, in the clinic, how we do it. So for the occipital nerve, as you can see, if you have headache history, I'm sure among the audience, many of them have experienced headache, and if you have a neurologist, oftentimes you go into the clinic, the neurologist will either bluntly inject in the occipital area, numb up your occipital nerve, or under the ultrasound, they would provide a more precise injection to block the nerve, right? And then you get a couple of days relief. and that's about it, and then there's long-term solutions is lacking, is not there. And this is how you do it. And as you can see, the occipital nerve really comes out from here at the C2-DRG. And if you take a dive deeper into cadaver study, it's the C2-DRG is actually very easily accessible. In contrast to C1 and C3, they're behind the anterior to the bone mass. The C2-DRG is behind the bone mass, and you're able to access it from the skin. So for example, on here on this side, this is the C2-DRG, and it's behind the bone structure, the C1, C2 facet. So imagine here is the skin, you can just go in there. So become a very, very minimal invasive outpatient procedure. Of course, that if you want to go into the C3, you have to cut the bone to go in. Okay. So in the neurosurgery literature, a lot of neurosurgery in the past, they would go open up and then cut out the C2-DRG. It's called ganglionectomy to treat this type of intractable headache. And I think our neurosurgical colleagues have helped many patients by doing this procedure, offering this procedure. And I think that some of our Chiari patients could benefit from this surgery as well. But it's an invasive procedure, and I think that loss of function may not be the most ideal procedure for this group of patients. The reason, as we talked about before, is many of these headache patients, they have trigeminal nerve, dorsal C2-DRG, dorsal root, they converge together, what we call trigeminal cervical complex pathway sensitization, elevation. Sensitization is not restored by cutting out the input. Sometimes you actually have to modulate it, stimulate it to down-regulate the pathway activity. So this is kind of the foundations that set down the reasons for me to start my clinical work over the last several years, is that I start to target this area as a way to treat my patients. I started by doing this C1, C2 facet joint injection because some of my patients, they have a lot of tightness here and some arthritis here too, and that could irritate the C2-DRG just overlaying this facet, right? And if I see a clear arthritic changes, and then I will go in there to inject some steroids and see how that do. And now, because we know that this could be done safely through percutaneous procedures, so I started to offer this as a routine procedure. And I've seen some success, and I was very encouraged to the point that I started to offer this neuromodulation for my patients about 2 to 3 years ago. Started as one, this patient, my young patient, has this kind of she doesn't have a Chiari, but she had this kind of a migraine headache every day, but mimics both migraine and tension headache. It's just that it's non-stop headache since she was in 20. So she had 10 years of issues. Then I injected the facet for her, but she's too young for that, right? She doesn't have much of arthritic changes there. And then, I had a long discussion with her that I said that we might be able to bring some difference for you if I put an electrode there at the C1, C2 facet, and then by modulating, still stimulating the C2-DRG, then I think this pathway could be renormalized and your headache may be better. This is what we did for her, and as you can see, there's a very small wire, that's electrode. The electrode is right at the C1, C2, where the C2-DRG is. We start to stimulate her 30 minutes a day, just in the morning. The FDA approved for this device for 2 months of use, okay, only 60 days. And we had a great outcome for this patient. And I was very encouraged, and we started to offer for more patients. And this is a patient who had a headache for 20 plus years and tried almost everything you can imagine. And we put a temporary leads for her. This is how it looks. It's 30 minutes of procedures. And you can see the leads is at the C1, C2, and going up is right here, the C1, C2, where the DRG comes out. And then when you stimulate, she's going to feel like a very pleasant buzzing arising from the back of head, radiate as far as to her face, right? Because this is trigeminal nerve territory, this occipital territory, they merge together to the brainstem. You're stimulating the back, the occipital area, the patient actually feels the brainstem and retrogradely spread to the face. And do that just 30 minutes a day, and we're able to help this patient, a headache for 20 years, cut down 50%. Unfortunately, this device can only last for 60 days, so we had to pull out after 60 days, which is like, I have one of the patient I'll share with you, that she's a physician from Arizona. I did this for her, and she doesn't want to take out. She just disappeared, and she just doesn't want me to call her. And I was so worried. I keep writing her emails every day, and I say, you gotta take care of it. Make sure there's no infection. Come to me. I need to pull out for her. Eventually, she came back, and after 3 or 4 months, it was not infected. She took care of it very, very well, and we pull out. Her headache's gone, and she is very happy for me to share with you all. And she got promoted to be associate professor last year, and I was so happy for her. So that's kind of one of the successful story, and then keep me going. So end of last year, we got IIB approval at Stanford. Is we're gonna using this peripheral nerve stimulators to target the great occipital nerve at the C2 GRG. We're trying to use as both preventive therapy as well as abortive therapy for headache patient. Our first indication is for for chronic migraine patient. But I think there is no reasons we cannot try this treatment for our Chiari headache patient with migrainous features or even tension headache, because there's really not much else is out there for you. And then we're also developing a wireless rechargeable peripheral nerve stimulators system to treat neurological disease, including the situations we just talked about before through e-wares and collaboration, etc. And we have the prototypes. But university research is always slow, so we're working on it. And so with that, I wanted to introduce you our facial pain program. And over the last 10 years, we really have built up a true multidisciplinary team, with, of course, with the support from mainly from our neurosurgery colleague and neurology colleagues. That we have more than 20 physicians in our group to help treat headache patients together, facial pain together. And our goal is to really treat each patient via a personal approach. Like everyone comes into our clinic, we don't want to treat you as okay, you have a headache and this is our approach. No, we want to know what's going on with you. What is the cause of your headache? What is the subtype of your headache? And what would be the most optimal treatment for you? And we want to develop innovative therapies for our patients so that when they come to Stanford, they might be able to find a different clinical outcome, different answers for it. And then we have some of the research that's going on there. So this is my reference, and this concludes my talk. And I appreciate these opportunities, and I will be more than happy to share my contact information if there are patients interested in coming to Stanford Pain Clinic and to get evaluated. And I cannot promise you I will cure your headache, but I can promise you one thing: I'll give my 100% effort, because I'm interested in headache and I'm interested in treating headache patients. Thank you.